Bismillahirrahmanirrahim. Assalamu alaikum. Welcome to the channel. Today it is in the continuation of what we are talking about, granulomatous diseases of the nose and paranasal sinuses. So bacterial granulomas we have already covered. So today we will try to cover another entity, which is fungal granulomas of the nose and paranasal sinuses. You are requested to like, share and subscribe the channel so that you are not going to miss any important topic. This is the basic classification which we are following, and same we will continue today. That rhinitis, it is divided into infected and non-infected. This non-infected can be allergic or non-allergic, which is vasomotor rhinitis. Then infected can be acute or chronic according to the duration of the symptomatology. Then acute can be bacterial and viral according to the etiology. Chronic can be specific or non-specific. This non-specific can be atrophic, chronic hypertrophic, then rhinitis sicca, rhinitis caseosa, and this granulomatous rhinitis which we are talking about. Then comes the question, that basic question again, that after all, how we define granuloma. This is a focus of chronic inflammations consisting of a microscopic aggregation of the macrophages that are transformed into epithelium-like cells, and these are surrounded by a collar of mononucleated leukocytes, usually the lymphocytes and occasionally the plasma cells. So this is a histopathological definition of a granuloma, which is common in all these different types of granulomas with some specific cellular infiltration in individual granulomas. So according to the etiology, if it is a bacterial granuloma, it can be rhinoscleroma, syphilis, tuberculosis, lupus, leprosy, and I have already uploaded the videos in which all these bacterial granulomas are discussed, and the link for those videos is there in the description box. You can check it out there. So this is according to etiology. If it is due to fungus, then we label it as fungal granulomas, and there are so many fungal granulomas, and this is for today's topic. We are going to cover all these granulomas one by one. Then there is another third group which is under the heading of unspecified cause, that exact etiology is not known, and it includes Wagner's granulomatosis, then T-cell lymphoma, sarcoidosis, and Churg-Strauss syndrome. In coming videos we will try to cover these granulomas as well. So coming back for today's topic, which is fungal granulomas. So as you can see that these fungal granulomas, these can be according to the fungi which are causing these. So upper three, these are more common in case of nose and paranasal sinuses, and the last three, these are rare in case of nose and paranasal sinuses. As far as this candidiasis is concerned, this is common inhabitant in the oral cavity and oropharynx, and it is also known as oral thrush, and every one of you would have heard this terminology. So this candidiasis or oral thrush is, as the name indicates, more common in oral cavity and oropharynx, while in case of nose it is rare. So we come to upper three one by one. We will try to cover that. So first of all, we will cover this rhinosporidiosis. So in bacterial granuloma, there is a granuloma with the name of rhinoscleroma, and while discussing that, I stressed upon, don't confuse rhinoscleroma, which is a bacterial granuloma, with this rhinosporidiosis, which is a fungal granuloma. So this is very important. So this fungal granuloma, which is rhinosporidiosis, this is caused by Rhinosporidium seberi, and it predominantly affects the mucous membrane of the nose and the nasopharynx, and it is characterized by formation of papillomatous and polypoidal lesions. It occasionally involves the lips, palate, uvula, maxillary antrum, conjunctiva, lacrimal sac, epiglottis, larynx, trachea, bronchus, ear, scalp, skin, and genitalia. Then it affects humans as well as animals, and in more than 90% of the patients, they usually are present in our subcontinent, that is Pakistan, India, and Sri Lanka. And it is more common in males as compared to females. The ratio is 4 to 1, so 4 times more common in males. The reason being, I just come to the etiology, and it affects the middle-aged men more, and that is 20 to 40 years of age. The reason being that the mode of infection is these uh, infected horses and cattle, and the dust from the dung of these infected horses and cattle, that is a source of infection, and usually adult males are the ones who are dealing with these animals. Then contaminated water of the ponds, especially in our rural areas, which is contaminated due to the uh, contamination of the water, which is due to the frequented by the animals, that they do urinate inside the ponds water, so this water becomes contaminated. Then contact transmission, maybe by the contaminated finger nails as well. So as far as this Rhinosporidium seberi is concerned, initially it was thought to be a sporozoa. Then it was classified uh, under the fungus, that is Olipidaceae, by the Ashworth, and recently they have placed it under a protozoa or a fish parasite, because the PCR tests have not demonstrated fungal proteins, so they thought that it is a protozoa, or it can be a fish parasite belonging to a clade which is abbreviated as DRIP, D-R-I-P, DRIP clade, which stands for Dermocystadium rosati agent, Ichthyophonus, and Sorospermum. You can check it from the book, otherwise no need to go into that much detail. But still, in your routine books, it is under the heading of fungus, so we will include it in fungal granulomas. Then the life cycle of this Rhinosporidium seberi, it is basically, there are 3 stages. One is maturation of the trophocytes, then development of sporangia and endospores, and later on there is release of these endospores. Just briefly, I will describe these stages one by one. That it starts its life cycle in the connective tissue as rounded oval spores, which are 6 to 8 micron in size, and it has got a cell membrane, and there is a central nucleus, vesicular nucleus, with a nucleolus inside. Then it is surrounded by a clear cytoplasm, and outside is a cell membrane, which we call as chitinous wall. And then it undergoes development by mitotic divisions and condensation of the cytoplasm, forming small endospores. Then development of sporangia and endospores, the trophocytes, they gradually increase in size, and now the size has come to from 6 to 8 micron, it has gone up to 200 to 250 microns, and it develops sporangium. This sporangium, it has got now thick wall, which has got 2 layers. The inner layer is the cellulose layer, and outer one is the chitinous layer. Inner cellulose layer is thin at the site where a pore will be formed later on, from where there will be release of these endospores. Sporangium consists of 12,000 to 6,000 endospores. So this is a second stage. And the third stage is, as this mitotic division and growth is going on, so there will be release of the spores, because now the number of spores have increased in size. So through the pore in the cellulose layer, they are released. Now this release of the spores, it depends upon two methods. First is that when pressure inside is too high, due to the increased number of these endospores, the sporangium, it ruptures at the weakest point, and there is release of these endospores. When internal pressure is not too high, the spores escape through the pore one by one, and after release they enter the surrounding tissues and they are carried by the lymphatic currents, so that it can involve different areas in the body. So this is then is the diagrammatic representation what we just talked about, that there is a release of these endospores, then there is this trophocyte, maturation of this trophocytes takes place, sporangium increases. Here is a single layer which is a chitinous layer. Here there are two layers, inner is the cellulose layer, outer is chitinous layers. Endospores are increasing in number, and ultimately due to increased pressure inside or by the weakest point through the pore one by one, there is a release. So this is the life cycle of this Rhinosporidium sphaeri. As I just mentioned, it can involve different areas in the body. So accordingly, it can be classified as nasal rhinosporiodosis, as the name indicates, ocular rhinosporiodosis when eye is involved, cutaneous when skin is involved, and miscellaneous rhinosporiodosis when different parts of the body is involved. So we will focus on nasal rhinosporiodosis. The patient may present with nasal bleeding, nasal obstruction, nasal discharge, foreign body sensation in the nose, and a typical feature of this rhinosporiodosis is that it may involve the septum nasal floor are turbinate, and it presents as a bright pink to purple in color, a leafy, friable, highly vascular polypoid mass inside the nose, which is attached either to the nasal septum or to the lateral wall of the nose. So there is highly vascular polypoidal leafy friable mass which is attached either to the medial wall, that is nasal septum, or to the lateral nasal wall, and this growth may extend posteriorly up to the nasopharynx, and even it can involve oropharynx, and anteriorly it may hang outside the nose up to the lips. Because it is highly vascular, so it will bleed on touch, and its surface is studded with white dots, and these white dots, they are actually representing the sporangia of the fungus. So their appearance is just like a strawberry. Strawberry, we know that it has got a whitish spots over its surface. Basically it is pinkish in color. So same, it is strawberry appearance of this polypoidal mass inside the nose. The nasal mucosa is generally swollen and hyperemic, and there may be thin mucoid blood stained nasal discharge and nasal stuffiness. And so this is the presentation of this polypoidal mass, as you can see in the picture, and there are whitish spots due to sporangium, and this is strawberry appearance. Another picture, more clearly it is showing. Now you can see whitish spots are there, so it is strawberry type appearance of this nasal mass or polyp. Even it is hanging posteriorly up to the oropharynx. Same in the nose here. Again in the oropharynx, here is behind the uvula. This is involving the skin of the nose, face, hands. So this is cutaneous rhinosporiodosis. So microscopically examination of the nasal discharge will show the spores. Biopsy and histological examination will show several sporangia, oval or rounded in shape, filled with the spores. which may be seen bursting through its chitinous wall. It has not been possible to culture the organism or transfer the disease to the experimental animal. So in the histopathological picture, there will be at different stages. For example, this one, number 3 with blue arrow, this is showing an immature sporangium, while with the red arrow, it is showing a mature sporangium, and with the spores inside this mature sporangium. So this will be a mixed picture from immature to mature sporangium will be present there, and in mature there will be endospores present. So surgically we have to completely excise that friable polypidal mass with a diathermy knife, and important is that do the cauterization of its base so that recurrence is not there, which is not uncommon. And medically, recently it has been seen that dapsone is effective against this Rhinosporidium berry, and it is controlling the rhinosporiodosis. So there will be a chance for you also. So thanks for watching, and don't forget to subscribe the channel